Good morning, sir. Shall I start the case, sir?
Yeah, yes.
My patient is a 53-year-old female resident of West Bengal, homemaker by occupation. Came with the chief complaints of yellowish discoloration of eyes for the past 4 months. Patient had history of pain in the right upper quadrant for the past 1 month, for which she was evaluated and diagnosed to have symptomatic cholelithiasis in May 2023. She underwent laparoscopic cholecystectomy on 25th of May 2023. Operative notes is not available. Duration of surgery was told to be 1 hour and was told to be uneven full. A drain was placed intra-op and she did not receive any intra or post-operative transfusion of any blood or blood products. I'd also like to know the biopsy report if it was sent. And on post-operative day 1, bile was noted in the drain mounting to 100 ml and she was managed symptomatically with medications and then she was discharged after 1 week with drain in situ. At discharge, the bilious output from the drain was around 75 ml per day. A week later, the drain output gradually reduced to nil, following which she developed abdominal pain and fever in the next few days. She was readmitted and evaluated with imaging, and her drain was repositioned. 200 ml of purulent discharge was noted, and she was managed with IV antibiotics and IV fluids and was discharged with drain in situ. At this point, I would like to know whether she was passing colic or ecolic stools and whether there was any history of any endoscopic interventions. Then over the next 30 days, her drain output gradually reduced to nil and it was subsequently removed. Patient remained asymptomatic for the next 3 to 4 months. I'd like to know during this asymptomatic period, was she under regular follow-up? Was any review, further imaging or blood investigations were done? In November 2023, she started noticing yellowish discoloration of her eyes and urine with mild dull aching, continuous upper abdominal pain with loss of appetite. I would like to know whether it was associated with clay color stools and pruritus. She then consulted a local physician for the same complaints and was given few oral medications, despite which she continued to notice a gradual deepening of the yellowish discoloration in this period. 2 months later, she developed episodes of intermittent fever and was referred to a tertiary center where she was further evaluated with blood investigations and imaging. A tube was placed percutaneously under ultrasound guidance, which drained greenish fluid on 17th of February 2024, following which her symptoms gradually improved and fever spikes reduced. Currently, she has mild yellowish discoloration of her eyes and urine, and otherwise she is asymptomatic for the past 1 month. The percutaneous drain placed is draining 100 ml of bile per day. I would also like to know whether there is any history or suggestive of any malnutrition or fat soluble vitamin deficiency and history suggestive of any liver failure or portal hypertension. And I would like to know if there is any history of lump in the abdomen, loss of weight, and any history suggestive of distant metastasis. In past history, there's no history of any medical comorbidities. As already mentioned, she underwent laparoscopic cholecystectomy on 25th of May last year. There is no similar complaints. Family history is non-contributory, and personal history shows normal sleep. There's loss of appetite, reduced appetite. Bowel and bladder habits are normal and regular. She consumes mixed diet, and there's no addictions. Shall I summarize the case?
Yeah.
So my patient is a 53-year-old lady post laparoscopic cholecystectomy 10 months ago with bile leak from drain since postoperative day 1, followed by drain repositioning a week later and spontaneous closure of the drain output after 30 days and drain removal subsequently. With history of painful progressive jaundice started 4 to 5 months postoperatively with intermittent fever episodes suggestive of cholangitis, for which she underwent an ultrasound guided percutaneous tube placement, probably a PTBD, draining greenish fluid suggestive of infected bile, after which she had shown improvement in her symptoms.
So, Vignesh, you have an approximate timeline here of the time when she underwent laparoscopy and then, drainage and removal of drainage and reinsertion and so on. Can you imagine what could have happened during laparoscopy? Why a drain and what could have happened?
The surgeon must have surely had a suspicion of injury, sir. Otherwise, routine lab chole, we don't usually place drains. So there must have been a doubt intraoperatively. So for that, he must have placed a drain, and it would have been a bile leak uh, which it's a cut injury mostly because since day one itself the bile started coming from the drains, and there could be the most likely scenario would be, sir, the it could have been a lateral injury or a lateral injury to the bile duct, which healed over a period of 30 to 40 days post-operatively, and then it with an associated probable ischemic part, so that it later developed to a stricture after quite bit of time. Only it started developing a stricture only after 4 to 5 months post-operatively. In between 3 to 4 months, she was asymptomatic.
When the patient came to see you, what more you would have wanted from the patient or from the history um, before you proceed further? What
At this,
extra? Yeah,
yes, sir.
to start
Sir,
with, when the patient saw you first, yeah.
yes, sir. At this point of time, I am seeing the patient for the first time now, so I would like to get the imaging since her preoperative period, sir.
Why?
Sir, if there was any, because particularly there was no biopsy sent, and I would like to know whether there was any cholecystitis or any suspicious wall thickening in the preoperative period. I'd like to see that from the preoperative image. Was it missed by the operating surgeon? And then subsequently, I'd like to see the imagings done at every point
No, no.
and
Regarding the first image, is the malignancy a suspicion or anything more than that?
sir, I'd like to see any, was there any Mirizi syndrome type of picture?
Yeah. Why is it important to have an idea of the preoperative imaging?
Sir, it can give us an idea about the level and type of injury that might have occurred, sir. If it was a Mirizi
So,
injury,
first of all, we'll know whether it's a difficult cholecystectomy or not,
yes, sir.
whether it is an acute cholecystitis or not, and because that might throw light on a possible difficult callus at the time of surgery. Yes,
Yes, sir.
and you would also would like to know whether the what is the was she operated in an acute episode or was it a routine electrical cholecystectomy? And if there's an acute episode, what is the gap between the time of symptom to time of surgery?
Yes, sir.
Right. So, what is the next important thing you would like to know from the patient?
Sir, I'd then like to get the operative records, sir. And
Yeah, very right. How do you get the operator record?
sir, either I'll ask her the discharge summary operative notes, or I talk to the
Was it
surgeon.
available?
It wasn't available, sir.
Yeah. More than the operator record, you would also like to have the video if it is available.
Yes, sir.
Why do you want to have the video and why do you want to have the operator record?
Sir, the operative records and the video would be even more important while dealing with an acute bile duct injury, sir. Now it has formed a stricture, but the operative details would give me an idea about the type of injury, whether there was an ischemic injury or not, whether there was an associated vascular injury, either it would give me details
You
about
think
that.
there could have been associated vascular injury?
In this case, sir, it there I don't suspect any vascular injury, sir, but
Why?
that, sir, because there was no history of any blood transfusions during the intra or post-op period, sir.
And the duration, is an hour.
Yes, sir.
Now, if the patient would have had a cholecystectomy and drain is leaking bile, and you would have seen the patient on day 4, day 5, what would you have done?
Sir, me in a tertiary center, working in a tertiary center, I would have in post-op day 4 or 5, I'm seeing bile from the drain. I would have done an ultrasound abdomen initially and look for any collections. And if there was any bilioma or collection in the drain, I would have tried to
There's some
drain that.
bile draining. I mean, there's a bile draining. I
Yes.
mean, the collection is superfluous. Yeah, what else?
Yes, sir. I like to basically manage the patient's sepsis and hydration status. And then if I'd like to monitor the drain output, sir. If it was continuously more than 200 or 300 ml per day and it's not in the reducing trend for at least 5 to 7 days, then and associatedly, if I could prove there is a bilioentry continuity, then I'd like to go for a ERCP, sir.
So you have considered ERCP to locate the leak and categorize it to decide whether the leak will stop on its own or whether that require intervention. Venu.
Yes, yes.
Sorry, sir. But doctor, we want to wait for 1 week. And do you want to do something before ERCP, or what is your plan? Are you happy with the way the patient is managed in this case, or what differently would you have done in this case?
Yes, sir, not at all, sir. I would have done many things differently, sir. First of all,
Yeah.
when there was a bile from the post-op day one and they had managed the patient 1 week in their own hospital, and we have studies showing that
No,
early
what would you
referral.
have done for post-op day one bile leak in this patient? What would you have done?
Yes, sir. If I'm in a nursing home, I would have immediately referred them to a tertiary center. If I am already in a tertiary center with a hepatobiliary interventional radiology and expert endoscope is available at my center, then I would have uh, manage the patient. If the drain output I would have seen for at least 3 4 days, whether the drain output is reducing or not, whether the patient is improving or not. If the patient is not improving and the drain output isn't reducing, then I would like, after confirming the bilioenteric continuity, I'd like to go for an ERCP.
How do you confirm biliary entry continuity?
Sir, a simple bedside test would be to see the color of the stool, sir. If the patient is passing colic stools, that could mean that the patient has only a partial biliary bile duct injury or a lateral injury. So, and we can either go for an MRCP or a HIDA scan to confirm biliary
No, no. What are
continuity.
you going to do in this? That's exactly is my question. So before you, do you want directly to jump to ERCP, or do you want to have a biliary anatomy before? So what will the suspicion is? Patient is draining bile, obviously was stable, just 100 ml per day was draining. What would be your suspicion and what is your plan for this case? We are talking about the first week, first day. You said you will observe for 4 days. Clinically, for sign there was nothing. It was
Yes,
controlled.
sir.
There was no fever, ultrasound was done, no collection. So what would have done and when you
Yes,
would
sir.
have?
If the patient was stable and the drain output was 100 ml per day and was gradually reducing, I would have not done anything, sir. I would have just monitored the
For how
patient. If,
long?
sir, for about a week, sir, because cystic duct type A type of Strasbourg injury should spontaneously close or show a tendency towards closure by at least a week to 10 days, sir.
Okay.
So if it is not reducing, if then I'd like to go for an ERCP.
Direct ERCP?
No, sir. If
What are
if
the
we sus-
what are the likely causes of bile leak in this patient? If patient is stable and a control what is your thinking process? One, you said lateral injury only you are suspecting. What are the other likely causes?
Yes, sir, I'd like to know whether the patient was passing colic stools or ecolic stools
Yeah,
by seeing the operative video and by knowing if
operative
there
video is not
was.
available. You'll see operative video is not available. Patient was referred to you. So
Okay,
patient, one you said lateral injury is one suspicion of bile leak. We are talking about bile leak in day 1 week and 100 ml per day. Patient is stable. What are the other
yes, sir.
suspicions? One is lateral injury. You said. Any other suspicion you have?
Yes, sir. It could be a type A or type C or a type D injury, sir. So if it was a complete transection, the quantity of bile leak would be more, sir, particularly in the immediate post-operative period. So
Immediate injury, can it be a missed CBD stone with cystic duct blowout or cystic duct blowout also? Is it possible?
yes, sir. Slipped or a missed CBD stones with cystic duct stump blowout could also be a possibility.
Isn't it? It's not only injury, the other things also are possible. So
Yes,
that's
sir.
what, before proceeding for ERCP, do you want to do any any other investigation simple, which is non-invasive and give a roadmap for further intervention, or you directly want to jump for ERCP? When you do directly ERCP and when you want to do a non-invasive imaging like MRCP, before
Sir,
going?
if with the clinical picture, I am sure that it is a type A or type D injury, then I'd go for an ERCP
Now,
directly,
how are
sir.
you sure of type A? It's just control everything by leak.
Yes, sir. If I'm able to see the operative video and talk to the surgeon, if I'm seeing colic stools for the patient and the output is only 100 ml per day since POD1, it's unlikely to be a complete transaction, sir. But if there is any doubt in these following parameters, then I'd like to get an MRCP done uh, and then go for an ERCP to ensure brilliant treatment.
So your comments.
Yeah. Now, do you think Dr. Shabeer there? No, it's not there.
Yes, sir. Yeah.
Yeah,
Hello.
Shabeer, your comment before I come in again.
Yeah, I think we discussed most of the things. You specifically mentioned you want to see the biopsy. What was in your mind when you wanted to see the biopsy of the?
Yes, sir. I particularly not knowing the pre-op imagings, and we know that incidental CAGBs is also a possibility. And we don't know whether they've, since we don't have the operative records, we don't know whether they've removed the entire gallbladder or not. So I like to see the biopsy for that and review the biopsy slides. So till I see that, I'll also keep a remote possibility of a malignancy in this case at the back of my head, sir, till I rule out this by seeing the biopsy.
Okay. Is it a common presentation like this with a bile
It
leak?
is no, sir. Bile duct injury with bile leak or a bile duct injury with an incidental CAGB is rather not a common presentation, but uh, that's why. But before seeing the biopsy and reviewing the slides, I cannot confirm and rule it out, sir.
As a remote possibility.
Yes.
Okay.
Vignesh, did the surgeon, do you think, a suspected bile duct injury in this patient?
Sir.
Or did he put it right?
Yes, sir. The surgery was only 1 hour duration, but they had placed a drain after laparoscopic
Is
cholecystectomy,
it
which
usually done? Is a drain is usually put?
no, sir,
When do
no,
you
sir.
put a drain?
We put a drain only when there has been a bile spill, when there is we suspect postoperative collections, when we suspect a possible bile leak or a cautery
Postoperative
injury.
collection is a different thing. On table, I mean, it's not a common thing to put a drain.
Yes, sir.
But we do not know whether that is an acute cholecystitis, and I'm sure because in our they finished, so there couldn't have been a difficult cholecystectomy. Why do you think? Do you think they have suspected a bile duct injury?
Yes, sir. They suspected a bile duct injury. They must have seen bile intraoperatively, sir. That's why it prompted them to put a.
Would you just put a drain if you see bile leaking?
Yes, sir. Again, if I am in a setup where I have the my senior backup and the instruments and all the backup, then being a GA surgeon, I would try to proceed further and rather than. But if I am in a nursing home without any backup or setup, then I'd put a drain and refer the
No.
case.
Dr. Vignesh, you are only stuck in bile duct injury. The leak from can happen due to many reasons. What all when you place a drain after lap, can you discuss? Sometimes cystic duct may be wide, it is flopping, or you're not able to close the cystic duct, isn't it?
Yes, sir.
All those
Yes,
scenarios
sir.
are also there.
Yes, sir.
Isn't it? So why you are only focusing on injury? You're not sure of whether injuries happened or not. So sorry, I ask you a simple question. When you place a drain in lap,
Yes, sir. So
one is
when
definitely if injury is suspected, then if it is CISA, you place a drain and shift to a better center. But other scenarios are also there where you place a drain, isn't it?
yes.
So you should enumerate them also. Isn't it?
Sir, this case it was possibly only a symptomatic cholelithiasis according to the history. There was no acute cholecystitis. So for a symptomatic elective cholecystectomy and duration of surgery being 1 hour without any difficulty faced intraoperatively, I could think of only reasons like either a bile leak or a bile duct injury.
See, Vignesh, quite often, whenever there is a definitive suspicion of bile duct injury, many a surgeon will try convert. Because if there is conversion to open cholecystectomy, I could have seriously thought that these people have suspected a bile duct injury. Since you say that it's in one, is not a tertiary center, then, the next important thing is that if there is a suspicion that there is an injury, they will refer to another center. Was the patient referred?
The patient was not referred till very late, sir.
So when the patient wasn't referred means that that must have been their custom to keep a drain in all prostatectomies, or they would have had some little suspicion, but they don't have a suspicion of a bile duct injury. Active bile duct injury which they could identify. Because this is another important thing that you should know from the patient, whether the patient was referred to another center or the patient didn't go or didn't follow. But that's the convention. If you if you identify, if you have the ability to do something, you will go in and do same time. But there's a conversion is an indication that the bile duct injury has been identified. Second thing is a patient referred to another center is also an indication that some injury is identified. It looks like these people who were involved didn't really suspect a bile duct injury. Now the patient has had a leak, had a drain removed, and come back again. And that time, just another drain was inserted. Was any imaging done to see the biliary tree at that
Sir,
juncture?
the drain was blocked and
Who managed that second episode? Same group?
same, according to the history, the same hospital, sir. Yes.
If these people could put in a drain again, that should be a good center. It can't be a simple center to have ultrasound guided. Now, at that juncture,
I think they have repositioned, sir. They have
They've repositioned the surgically placed drains.
So they are
they
doing new
didn't
one.
insert a new one.
No,
No,
no.
sir.
Now, what would you done at that juncture if you were the surgeon?
Yes, sir. If I see the patient again at 7 days with a blocked drain and with fever and abdominal pain, again, depending on the center I'm in and with the expertise I have, if I'm in a tertiary center being a GI surgeon, then I'd do an ultrasound imaging first to see whether there is any bilioma, and I'd either reposition the drain or I'd put in a percutaneous drain catheter, and I'll drain the collection and I'll manage the sepsis part of the patient. And then, as discussed already, sir, I'll monitor the drain output and the patient's condition serially. And based on the trend of the drain output and the patient's clinical condition, then I'll either wait and watch or I'll
No,
go
no. At
for
7 days, you have repositioned. You don't want to do any further thing because obviously something serious is going on. You don't
Yes,
want
sir.
to further investigate drain reposition. Okay, they accept ultrasound and drainage of collections. Will you
Yes, sir. And
further
again,
investigate or do something is the question.
yes, sir. If the patient has signs of peritonitis
There
or
is no signs
sepsis,
of peritonitis. You repositioned it. Drain is controlled now. Gains draining now as per history.
okay, sir. So there's no signs of peritonitis or cholangitis or sepsis or shock, then I our institute protocol is we'll get a contrast and a CT scan of the abdomen, so to rule out any missed collections in the ultrasound, sir.
So if there is signs of sepsis, you are doing CT, and if there are no signs of sepsis, also you are doing CT. So in all patients, you get a CT scan after 1 week.
Yes, sir.
So this
Ultrasound
imaging, when you do this imaging, what all are you going to look for in addition to collection, say?
in the CECT abdomen, sir.
Hmm.
If in the immediate post-op period, if there is greenish bile and I also suspect a hollow viscous injury, I'd give a oral contrast to the patient along with an IV contrast, sir, to look for
You
diurnal.
suspect hollow viscous injury in this patient?
Not in this patient,
Patient, we are
sir.
talking about this patient. Yeah.
In this patient, I'd like to see any missed collections. If there is any the ISBRD would not have set in this soon. I'd like to see if there's any cholangiolytic abscesses present in the liver.
Why you don't want to do MRCP? That's 1 week. Patient is settled, control fistula is there. If you do MRCP, you'll get the biliary anatomy. Sometimes missed CBD stones will be there. You will know whether biliary entry continuity is there, whether lateral injury, complete cutoff. So many information will be available, which will guide your further treatment, isn't it? If the lateral injury is there and cystic overload, there is other treatment in the form of PRCP. So why you are not jumping when patient is not having sepsis? You want to do a CCT type? You want to still stick to the same investigation, or you want to modify your answer?
Sir, during the acute bile duct injury phase, with collections present in the abdomen, the
No, no,
MR.
no. This patient we are taking already brain reposition, brain sepsis control. In that scenario, we are speaking. Yes, if sepsis is there, collections are there, definitely CT scan is accepted. We are talking about scenario where reposition patient is improved.
Sir. So if we can rule out there are no collections in the abdomen GB fossa, then we can go for an MRCP, sir. But if there are collections, it would, if it is present on the HDL, it would hamper the visualization of the biliary anatomy in that acute period, sir.
So first your main target will be to drain the collections, then
Yes, sir.
no.
Yes.
So you'd also would like to have an idea about the vascular tree, whether there's any injury to the vascular tree. Whenever you have an opportunity to do the first cross-sectional imaging, you would like to see whether any arterial injury is there, which will impact on how the patient is going to recover. And you also would like to have a look at portal vein, how it looks like, whether any a patient wouldn't necessarily had bleeding requiring transfusions, but that's one other thing you would like to have a look. Shabeer?
Yes.
Yes, yes, sir. One thing I want to clarify, Vignesh, what Sir Radhakrishna sir and Venu Madhav sir is trying to tell you is, once you got a repeated problem, the patient where you have a wait and watch is when you have a drain is coming down and it's settling. But when you are getting again and again problem, patient comes back with a collection, definitely you should go for a MRCP to see the biliary continuity, and you should think about intervention at that stage once the acute sepsis is controlled. This patient is coming back at 1 month again with collections. So definitely that is the time where you need to evaluate the anatomy. It is not like you should be clear about which patient should go for a wait and watch and which patient you have to intervene early.
Yes.
Okay.
So what next now? Now that you have this history, the patient is seen you, and patient has jaundice and the suggestion of some sort of a cholangitis, what next? How would you proceed?
Complete the examination.
Oh yeah, sure. Examination.
Sir, on general physical examination, the patient is conscious, oriented to time, place, and person, moderately built and poorly nourished, with a low BMI of 16.8. Her breath holding time is 36 seconds. She has icterus present. There's no pallor, cyanosis, clubbing, pedal edema, or lymphadenopathy.
Just a minute, Vignesh. Isn't did she have significant weight loss or is original BMI like this?
So it's not mentioned, sir. I would like to know whether there was a history of
Is
loss
it
of weight.
usual you see a BMI like this in biliary injuries?
No, sir, but she has been having bile leak and jaundice for a chronic. Abhi, it's almost 10 months since her injury, sir. So she has been having bile leak in the initial 2 months and now for the past 1.5 months also, and jaundice for the past 4 months. So these all could contribute to poor nutrition. But I'd like to know the history, whether there was any significant loss of weight or not, sir. But this could either be due to jaundice and bile leak or could be due to a malignancy also. But if that is not the case, then she might be having a low weight to begin with. So I'd like to know the history of loss of weight.
So this is a very unusual thing to have this sort of a BMI. If the patient is originally of lower weight, is a different issue, but that's something one need to keep an eye on. Yeah, can you?
Yes. And vitally, she is stable with a pulse of 76 per minute, BP of 100/60, respiratory rate of 15 per minute, and afebrile. There are no clinical signs of dehydration or any signs of liver cell failure. On parabdominal examination, the abdomen is scaphoid and umbilicus is central and inverted. All quadrants move correspondingly with respiration. There are healthy, primarily healed port side scars. There's no visible peristalsis,
A
sinuses,
word
engorged
about
veins.
the port side scars. How
Yes, sir.
many were there?
It's not mentioned, sir.
No, because you examined, no, it's not a matter of mentioning. When you examine the patient, are you interested in counting the number of port sites?
Yes, sir. This case capsule was provided to me, sir. I did not examine the patient.
All right, okay,
So,
fine. Now here there are times when you have extra ports in, which would suggest that there is some struggle, some difficulty. So
yes, sir.
again, when the port sites are the same numbers, by and large, we understand that there was not much of a problem. Yeah.
Yes, sir. PTBD drain was noted, draining clear golden yellow bile of around 200 ml in the bag. On
Is it a
palpation,
PTPD drainage? Is that the right terminology?
PTBD catheter,
No. What does P stand in PTPD?
percutaneous transhepatic biliary
Is it a
drainage.
transhepatic drainage?
Yes, sir.
Usually also, sir. Later on, they placed a PTPD, transhepatic.
I suspect it to be a PTBD, sir, because she had jaundice, which led to cholangitis. So to relieve that, they must have done a PTBD.
I mean, a center is doing PTBD. I mean, is a big center. I mean, is PTBD usually done in this sort of patients?
No, sir. The PTBD was done in a tertiary center. They had referred at that point to a tertiary center, sir.
Okay, right.
So,
Yeah.
so the only indication in such a case to do a, PTBD would be cholangitis not responding to IV antibiotics.
Okay, fine. Right.
On palpation, abdomen is soft and non-tender. Liver and spleen are not palpable. There are no other palpable lumps. Hernial sites.
What is the
There's no,
significance of liver and spleen palpability?
sir, if the liver is enlarged, it could suggest cholestatic hepatomegaly, and even the early stages of secondary biliary cirrhosis, there will be hepatomegaly, sir. And if there is splenomegaly, it would suggest there is portal hypertension because of the secondary biliary cirrhosis leading to splenomegaly.
10 months is a reasonable period for all that to develop. Yeah, carry
Yes.
on.
And on percussion, the liver span is 14 centimeters, which I'd like to confirm it again because for such a short female, 140 centimeter height, 14 centimeter of liver span is on the higher side. And flanks are tympanic, there's no free fluid. Auscultation, normal bowel sounds are heard. On digital rectal examination, glove was stained with normal feces mentioned, which I assume it to be colic stools, and the sphincter tone was normal. Other system examinations were grossly within normal limits, sir. Respiratory, CVS, and CNS. So, on summarizing my history and examination, so we have a 53-year-old lady post-lap cholecystectomy 10 months ago with bile leak from drain since POD1 and drain repositioning 1 week later and spontaneous closure of the drain output 30 days. And then 4 to 5 months post-op, she had painful progressive jaundice with intermittent fever episodes suggestive of cholangitis. She underwent a PTBD placement, which drained infective
ब्लैक
bile, and
जूते
then
निकाल देना बेटा
and
हाँ
then she gra- and then she
Carry on.
gradually
ब्लैक
improved in her
वाले जूते निकाल
On clinical examination, she has icterus present. She is poorly nourished. There are no clinical signs of sepsis, cholangitis, or liver cell failure currently. And she has a PTBD in situ, draining clear golden yellow bile, and she has colic stools on DRE.
Yeah. How would you proceed from now on?
Sir, first I'd like to review all her imagings and records chronologically, sir, right from her pre-op period till now. Or follow-up imagings at every period and her LFTs and her biopsy report if available. I'd like to review all those reports.
Now, presently, if this patient is presented to you in this position, in addition to the records, how will you proceed? What would be the plan? How will you proceed?
Sir, first I'd like to proceed in two ways. Sir. Once I'd like to confirm my diagnosis and simultaneously I'd like to manage the patient as well, sir. So to confirm my diagnosis, I'd go for an MR abdomen with an MRCP, sir. And then for managing the
And
patient,
what would you look for in a MR? What all would you look for?
Blood
sir,
investigation.
I'd first like to confirm my diagnosis of a benign biliary stricture, sir. I'd like to see the level of stricture. I'd like to see the extent of the stricture. And I'd like to see the entire biliary anatomy, if there are any separated ducts not draining into the hilum, and entire hilar anatomy and all the ducts I'd like to see. I'd like to see the liver outline, whether it's regular or not. I'd like to see if there's any trophy hypertrophy complex. I'd like to see if there's any cholangular abscesses. I like to see the I like to see the spleen and for ascites.
Before that, you have to do some investigations also, no? Before
Sorry,
imaging,
sir.
blood investigation, you don't want to do?
Yes, sir. Yes, sir. I'd like to do both simultaneously. Sir.
So what do you want to start with? But what investigation you want?
Sir, I'd like to get a liver function test, renal function test with serum electrolytes and a complete blood picture. Sir.
And we have investigations.
Yes.
So on 15th of February, the hemoglobin was 10.6, TLC 10,000, platelets 5 lakhs. So there's no evidence of any infection or sepsis, and there's no
Is that
hypersplenia.
pre-op or immediate post-op?
Sir, it's just 1 month back, sir, so 9 months post-op.
Right, okay.
Next, I'd like to look at the liver function and kidney function test.
Yes.
This is before PTBD placement. The liver function test showed bilirubin of 18 with a direct component of 9.
So what do these LFTs suggest? What will be the diagnosis based on the LFTs?
Sir, this would suggest a obstructive jaundice type of picture, sir, with cholangitis, because at that time she had fever and there is transaminitis as well, sir. So with jaundice, so she had cholangitis, obstructive jaundice with cholangitis.
And the nutrition part?
Her serum albumin was normal 3.6, sir.
Near normal.
Is the
Yes.
routine
Okay.
presentation for bile duct injury to present this much with this much bilirubin 8 after 10 months?
Sorry, sir.
Is this a routine presentation or for a
Yes, sir.
bile?
The onset of jaundice is a bit late, sir, than usual. It's has presented 5 months after the injury has occurred. Although it can occur, but it's usually occurs earlier. So,
The Venus worry is, do you get 18 bilirubin benign biliary strictures?
yes, sir. If it is a complete cutoff, we have seen even up to 20, 30.
Most of the patients, they don't, after stricture also, they don't have this much bilirubin. No? Why do you think they don't have that much?
If even after complete stricture they don't have this much bilirubin, then they must have had an internal biliary fistula, sir. Developed an internal biliary fistula.
The issue of cholangitis, is it seen in a partial obstruction or a complete obstruction?
Partial obstruction.
So this could be a partial obstruction.
Yes, sir.
And also, as you see that when you examine that the patient is normal colored stools on rectal examination.
Yes,
So
sir.
again, this sort of bilirubin is still worrying, but that one should keep in mind because 53-year-old and a mitosis can't be ruled out because when we have to go into different diagnosis, that should be one of the different diagnoses. Yeah.
Yes, yes.
What next? What other investigations?
I like to see the renal function test and serum electrolytes. Yes,
Right.
renal function test is normal. Electrolytes, sodium is a bit on the lower side, but potassium and chloride is normal.
So what next you want to do? Basic. INR you got, no? INR is how much?
0.8, sir.
Oh.
What is your inference on liver, status of liver from these investigations?
Sir, the synthetic function and the clotting function of the liver is maintained, sir.
What about platelets?
Platelets is also in 5 lakhs, sir, so there's no portal hypertension or hypersplenism in the blood picture.
What next? From here on, what next you want?
Is sir, to confirm
You
the
have LFT post PTBD?
No.
LFT currently has shown that the bilirubin has reduced from 18 to 4 with a direct component of 2. Alphas is 370. OTPTs have come down 94 and 91. Serum albumin is on the lower side, bit on the lower side 3.3, and INR is 0.9, which is normal. So
You also should understand that this albumin and her BMI don't sort of correlate.
yes, sir.
Maybe her BMI even earlier was low.
Lower, yes, sir.
Next, what next?
Next, I'd like to get an MRCP, MRI abdomen with an MRCP done to look for the anatomy and the inform a diagnosis.
You have the pictures?
Then outside, sir, we just have films of them.
Okay. The MRCP? Anything significant in this MRI? Do you find anything unusual? Go back.
So the liver outline seems regular, sir. The I'm able to see IHBRD. There is no crowding of the IHBRD in any segment suggestive of an atrophy. So grossly it appears normal, sir.
There's no splenomegaly, right?
There's no splenomegaly. Yes.
Okay. MRCP?
MRCP shows bilateral IHBRD. The confluence is primary biliary confluence is patent, and we are able to see a stump of I'm not sure about the measurements, but at least 1 or 2 centimeter below the confluence, I'm able to see the common hepatic duct dilated. And
As a GA surgeon, you're happy to see this MRCP or you're worried?
I am happy to see MRCP.
Why?
Sir, it appears to be a type 2 benign biliary stricture, sir, which has a almost 95 to 100% success rates with surgeries.
So this is a type 2 and is the best stricture anyone can have to operate, right? Okay,
Yes.
what next?
Yes, sir. So, and then I'd like to.
Venu, any comment on this?
No, sir, yes. So is there any crowding? Do you think any crowding is there, left lobe or lateral? Nothing.
No, sir.
No.
There doesn't seem to be any
You
crowding.
see the crowding, atrophy, hypertrophy complex, splenomegaly, everything you see because it's already 9 months old. So
Yes, sir. Yes.
you suspect
Yes.
in vascular injury in this patient based on this MRC.
Sorry, sir.
Any vascular injury is possible?
So there's no atrophy hypertrophy complexes, so I not suspect any portal vein injury basically. And
Any other suggestion on MRCP to show that there could have been a vascular injury? Any other suggestion that there's a vascular injury other than the lack of atrophy, hypertrophy complex?
sir, if it was a complex injury like a type 4 injury, high injury, then it could mean that there was a arterial injury in the first setting, which had led to high complex biliovascular injury, high injury.
So when you see that confluence and the stump is unlikely, and again when there is vascular injury, there could be intrahepatic biliary strictures as well. You know, which
Yes.
it turns into. Dr. Shastri has a question: why contrast study not done through the PTBD catheter?
Yes, sir. We can do a PTBD gram, sir, but the MRCP gives us a more holistic picture of the entire biliary anatomy. It can even give us idea about any undrained ducts which are not communicating with the hilum, and it can also give us an idea about the liver outline, atrophy, hypertrophy complex, cholangitis abscesses, etc. And since the patient is just now recovering from cholangitis, and I had not do a PTBD gram, and even if I do, I'd still like to go for an MRCP.
Okay, what next? Shabeer, you have comment here?
Nothing, sir.
Yeah, carry.
Sir, I'd like to optimize the patient now, sir, for surgery. I'd like to optimize the nutrition, her hydration status. I'd like to replenish fluids and
But
electrolytes.
none of
I'd
them
like,
seem to be abnormal. But what is there to optimize?
sir,
Bilirubin is down, cholangitis is down, nutrition is all more or less, albumin is okay. What exactly you mean by optimization?
yes, sir, I'd like to see if there are any vitamin deficiencies. I'd like to replenish fat soluble vitamins. I'd like to give her fluids, and even though there's no coagulopathy, I like to still give vitamin K injections.
Okay. No, but these all sound a bit superfluous because this could be the nicest patient you can have post biliary injury to operate. Okay, next,
Yes.
what next?
Yes, sir. Then once all this is done, I'd like to explain my plan to the patient, and I'll take her up for a
What will you
Venu
explain
hepatic.
her? What is that you're going to tell the patient relatives?
Sir, that
The,
there
the
was a
first question the patient relatives ask you is, has the previous doctor done it right?
yes, sir. So, I since I don't have access to the surgeon or the operative records, I can just explain to her about the situation with statistics. So, I'd like to tell that during a cholecystectomy surgery, there is a chance of there has been a bile duct injury in your case, and there is a chance that 0.2% of 0.2 to 0.5% of patients can get a bile duct injury, and that is what has happened in this case, and which has led to her developing a stricture and jaundice leading to cholangitis. So
The patient and relatives ask you whether subsequent management after the initial surgery, was it right, or the patient could have been referred to you earlier? These are the things they ask actually
yes, sir.
in my practice. What would you say?
So the definitely the patient should have been referred earlier to a tertiary
No, that
center,
is
sir.
that is between you and me, between you and the patient.
Yes, sir. I'd I I would I would tell that the if since she has not yet developed a secondary biliary cirrhosis and she's preserved till now, so I would tell her that I would have managed her even before her PTBD was placed if she had come earlier. But the management and the prognosis of having of operating now is not going to be any different. But I tell her that it would have been better if she was referred
Yeah,
earlier.
the bottom line is that we can't, you should be blaming the previous doctor.
Yes,
At every cost, you try, say that I really do not know the sequence of events and what is the expertise, this, that, and the other. I cannot comment on that.
yes,
It should be very, very diplomatic and at no cost. You should try to, because these days of, so much of a unrest in, this sort of patient-doctor relationship, this is a very important point that because whenever bad luck injuries happen, there's a huge furor over it. Okay. So that's an important point you have to keep in mind. Okay. Now, what is the treatment protocol? You explain the patient. What are you trying to tell the patient? You want to tell what are the options?
yes, sir. I'll explain to her that I'm taking her up for a surgery, sir.
If the patient asks you, sir, can this be done laparoscopically? What would you say?
Sir, it it can be done laparoscopically, sir, but it is better if it is done by open. And since uh, in our
Is that
center,
is that true?
for the in
That
this center,
laparoscopic, the open is better than laparoscopy?
in yes, sir, in bile duct injury with bile leak with additions, it
Is
is
there
better.
literature to support your statement?
Sir, literature shows its laparoscopy is not inferior to open.
Now the answer is it is possible, but I don't do.
Yes, sir, yes,
I don't do laparoscopically. We can't say that open is better than laparoscopy when literature is available that that there in good hands it can be done. But in my suggestion, I don't know. I am not done. Yeah, that's
yes,
a frank answer. Okay, now you're talking about the operative surgery. Yeah.
yes, sir.
Uh,
Vignesh, ask you one question. They may ask you, is there any other than surgery, is there any other option in this patient would you consider?
Uh, yes, sir. If since this seems like there's a complete cutoff in this, if there can be a endoscopic, there are people do managing type 2 strictures, type 1 and type 2 strictures endoscopically as well, sir. But such a low stricture, type 2 stricture having almost 100% success rate surgically, I would not offer them an endoscopic treatment at this point, sir. I would tell surgery has the best chance for her right now.
What are the disadvantages of endotherapy in this situation? Why you consider surgery?
Sir, in this case, she does not have a stent in place already, sir. If it is a complete cutoff, they cannot cannulate cannot negotiate through the stricture if it is a long stricture, sir. And they cannot negotiate and go there. And even if they can negotiate, the patient would require multiple stents, multiple sessions of endoscopy, and multiple a longer period of follow up. Around that, the procedure can go around up to even 1 year. So the patient who came just for a cholecystectomy surgery would want to forget this episode and move forward. So keeping them with the same pathology inside and keeping asking them to follow would be mentally also traumatic for them, sir. So giving a single time solution would be better for the patient.
Somewhere I saw an endo ultrasound being done in this patient. Yes or no?
No, sir, an ultrasound was done, sir, not an endoscopic ultrasound.
I know, I remember seeing. Anyway,
I,
okay.
I think an ERCP was attempted somewhere, and they tried to put a wire across before the PTBD.
Yes, sir.
We have that report.
Yeah.
Okay.
Okay.
We have, sir.
Okay. Now, how will you? But where did the wire go?
Yeah, what is this? Make sure.
Can you read this ERCP first? What are you saying?
Sir, I'm able to see the guide wire and I'm able to see the surgically placed clips. And
Where is the
Did,
wire?
did
I'm able
this patient have a pancreatic stent put inserted?
this is the distal CBD which is opacifying, sir.
Yeah.
No, the
And
wire.
there's complete
But
cutoff.
what
And
pancreatic stent is also seen.
this wire, probably they would try to cannulate the CBD and it inadvertently went into the pancreatic ducts.
Now, if this particular endoscopist has seen the MRCP, suppose if you are in the institution where would you agree to this attempt at TRCP?
No, sir, no, sir.
And why do they put a pancreatic stent normally?
If they have inadvertently cannulated, they put a prophylactic stent to reduce the chance of ERCP
Some
pancreatic.
inadvertently, even some electively also do that because this won't be. But then, do you agree with this attempt at ERCP to transgress the stricture?
No, sir, a complete stricture on MRCP, I would not accept.
This is not an ideal, definitely not a good patient to attempt all that because, as you said, although there are people who do it with multiple their attempts and then subsequently patient may develop secondary biliary cirrhosis, portal and surgery will become difficult and the complication rates will be quite high in this patient. So we are running
Can you
out of time.
comment?
What
One
are
minute. Can you comment on the clips? Where are the clips placed and what?
Sir, this seems like the clip which has been placed on the CBD, sir.
Yeah.
Vignesh, have you done a biliary stricture surgery
Yes, sir.
independently?
Yes,
Tell
sir.
me this. Tell us the steps of surgery. How do you proceed with positioning to?
Yes, sir. I'll keep the patient in supine position. The patient would be under GA and epidural. I'll give a right subcostal incision, and if there is a fatty patient or there's an issue with exposure, I'd extend the incision to the cover the midline also. I'll apply retractors, and then I'll start the adhesiolisis of the omentum and colon. I'll go from the right to the left. I'll go from the direction of adhesiolisis. I'll first take down the omental adhesions and the colonic adhesions, and then I'll slowly move towards the hilum, where the duodenum and antrum of the stomach might be adhered to the.
You see, the liver is stuck to the anterior abdominal wall. You'll not find any plane between the liver and the parietal peritoneum in the costal margin area. What will you do for that?
Yes, sir. I'll go from the virgin plane where there are less number of additions to the parietal wall from the liver, and I'll start doing the adhesiolisis sharply, and then I'll create a space to separate the liver, and then I'll apply the retractors.
How far would you separate the liver from the
From
diaphragm?
sir, I'd go as high as possible from the diaphragm so that I can apply the retractors and I'll have a space to push down the liver.
Yeah, actually, whenever you are operating on a biliary stricture, the liver should be fully dissected. So you should be able to put your hand over the right lobe and able to touch the upper pole of right kidney.
Yes, yes,
Only then the liver will come down.
yes,
So one, of course, you mobilize the hepatic flexure, and then you cut the falciform ligament. That's the first step you do.
yes, sir.
Before applying retractors, you would you cut the falciform ligament till where?
Falciform ligament, I'll cut it close to the umbilical fissure, sir. And then
And you
I'll go up
yeah.
till the, yes, sir, till the hepatic veins. I take it.
So when it bifurcates, there are two layers. Okay.
Yes.
Once you mobilize the liver and the colon, what next?
Yes, sir. Then I'll proceed towards the hilum, sir, where I'll take down the additions with the hilum and GB fossa of the duodenum and the antrum. I'll take those down and I'll expose the hilum, sir. And then I'd go to the base of the segment 4B and I'll lower down the hilar plate. And then I'll lower down, and
Where
then
will you
once,
find the duodenum in this patient?
so the duodenum would be stuck to the HDL where the immediately above the stricture point, I would find the duodenum being stuck.
So the bottom line of this biliary stricture surgery is that you don't go straight onto the. See, you come from the periphery, mobilize all, and then only come. So
Yes.
mobilize the liver, mobilize the colon, and then come, and you find the duodenum stuck just under the area which is injured. You disconnect the duodenum, suddenly there's a big gush of bile flow. That's how you identify the. And it should never be that you go straight on the duodenum and start dissecting it. You have to mobilize all around. Right.
Yes.
Now you found the area of stricture. Usually there'll be some communication between the duodenum and the stricture area. Some bile will be seen leaking out. What then? What do you do after that?
Sir, I'd like to put in a needle and I'll aspirate bile to check whether
Quite often the bile will be seen leaking out. Okay. Then what next?
yes. So then I'd once I've taken down the hilar plate as well, then I'll start making the choledochotomy in a vertical fashion from the CHD to the left hepatic duct, sir, as uh, as long as I can make in the and
As long as means where what's your endpoint?
sir, I need to make a wide stoma for the hepaticojejunostomy, sir. So that's why I take down the hilar plate and I extend my choledochotomy towards the
Venu
left
wants to know
hepatic.
what should be the length of the stomach and the biliary tree you want to ideal
Yes, sir.
size of the.
It is said it's 2.5 to 3 centimeters, sir, but it is not possible in every patient. So, yeah, according to each patient, whatever is the maximum length we can get, we need to time that in every patient.
So it's 9 o'clock. So can we
Yeah.
invite comments?
Yeah. Okay. Pradeep, the Kapoor is it? Sorry. Sir, would like to come in?
Morning. Good morning.
Morning.
VK Kapoor here. So a few points. At one stage, Vignesh, you said that because there is no history of intraoperative or post-operative transfusion, I will not consider vascular injury. Vascular injury is not synonymous with bleeding. You can have a clipped and divided vessel. That also is a vascular injury, but there will be no bleed. And same
Yes.
way, bile duct injury and bile leak are not synonyms. You can have a
Yes.
bile duct injury, but no bile leak.
Yes,
Although
sir.
invariably bile leak means bile duct injury. Now, between CT and MRI, the advantage CT has, one you already mentioned, that even in presence of a collection, it is helpful, which MRI may not be. And the other is that with oral and rectal contrast, you can simultaneously look for duodenal and colonic. You mentioned only oral, but it should be colonic contrast also, which is a disadvantage with MR. The advantage of MR is that it gives you the biliary ductal continuity. The methods to evaluate biliary ductal continuity, yes, you did mention. So, but you have to remember that even a patient with an internal fistula, which can occur at a later date, the patient may have colic stool, but there is no biliary ductal continuity. So, complete injury with internal fistula, the stool will be colored.
Yes.
Isotope scan is a good investigation. The only thing we have to remember that if there is a large volume fistula, then all the isotope will come out through the fistula, and biliary ductal continuity, even if it is present, may not be seen. So if you see biliary ductal continuity, it is there. If you don't see it, it can still be there. And that is why many people now feel that we will establish whether biliary ductal continuity is there or not at the time of ERCP only. So some people go straight away for an ERCP. In a patient who has had bile leak in the post-operative period, invariably the diagnosis will be bile duct injury. We do consider a missed gallbladder cancer, but that is more likely if the cholecystectomy was uneventful, there was no bile leak, jaundice appears few weeks or maybe even few months after the cholecystectomy, and then it is a progressive jaundice. Also, if there is a patient who has had an external fistula, bile leak and external fistula, and fistula closes, and then you have a long gap which is asymptomatic, no jaundice, no cholangitis, and then patient starts developing jaundice, that is another situation where you may think of a missed malignancy. There is a very subtle difference between terms like resuscitation, optimization, preparation, prehabilitation. So resuscitation is basically for hemodynamic instability. Optimization is mainly for metabolic instability. For example, a patient with gastric outlet obstruction who has electrolyte imbalance, or it could be nutritional optimization, it could be comorbidities optimization. And preparation is simple vitamin K administration in a patient with jaundice, ureteric cannulation in a large retroperitoneal tumor. So these are preparatory steps. In between, I missed, but I'm not sure whether an upper GI endoscopy was ever done in this case to look for varices. It had been our policy at SGPGI, a rough cutoff of about 6 months. Any patient who has biliary obstruction or biliary stasis for 6 months, we would always look for varices. Portal hypertension doesn't change your plan of management, but it prepares you well that both you and patient is prepared that in case it is difficult to access the biliary tree, then at the same time, you will change your plans. You will do a shunt first and then come back later for the biliary tree. The surgical approach, at one stage, you said, I'll go to the hilum. No, you can't go to the hilum straight away. You should not. You have to go from right to left. So you start taking the adhesions once you have done the mobilization of liver and retraction of the right costal margin. Then you go from right to left, starting from hepatic flexure, taking the colon down, and then you go from front to behind. And as Dr. Radhakrishna mentioned, that you reach the hilum at the end. Repeatedly, you use the word choledochotomy. I mean, it is only semantics, but I would prefer the term hepaticotomy because you are now working on the hepatic ducts. And the incision is not vertical, it is longitudinal. Vertical means vertical. Longitudinal means along the direction of the duct. So wherever, for example, if you have a small stump of the common hepatic duct, in that part, yes, it will be vertical. But then you extend it into the left duct, so that usually becomes horizontal or oblique. So best is to say a longitudinal incision along the direction of the duct.
Yes, sir.
So students, if you want to read more about bile duct injury and biliary stricture, send me a mail, vkkapoor.india@gmail.com. Write BDI in the subject of the mail. Thank you.
Thank you, sir. Dr. Shastri, sir.
Good morning. Vignesh, I think you've covered most of the areas fairly well. So it's a fairly straightforward case and quite simple for you. What is important for all the residents to remember is to know all the possible scenarios at various stages of the evolution of a biliary stricture and discuss various options in a given case. I think that would solve most of your problems in a biliary stricture. And I think most of the points are very well covered. I don't have anything much to add.
Thank you, sir. Dr. Yadav, you have a comment?
Good morning. Yes, I think every point has been covered. One important point only when people were asking what will you do in the post-operative period if you are the primary surgeon looking after this patient. So yeah, you only talked about ultrasound. It's very important. We always say if recovery is not expected, then we should do ultrasound and liver function test. Both are equally important. Sometimes there will be changes in the liver function. So it's important to do liver function test and this thing. Second important point, which we were discussing that about the MRCP, he told that the MRCP, once there is a controlled fistula and we are going to send the patient home, then at that particular time, we would like to have an idea so that we know that what type of biliary anatomy and biliary injury has occurred, and we explain the patients and relative that in the long term, this is going to happen. We will operate as we follow in PGI policy of delayed repair. So this is one important point. And the third important point regarding the management, somebody asked about endoscopic management. So I think Bridges is the name. So I suggest you to read very good article in 2018, JACS, all-American topmost biliary, doing biliary injury repairing surgeons, including Lilimo and Henry Pitt. They have published one about more than 7 lakh cases they have evaluated from the state of California. And it has been found that if you are doing managing the patient endoscopically, biliary stricture, now we are talking about biliary stricture, biliary bile duct injury, not talking about bile leak as Kapoor sir was emphasized. So the long-term outcome and cost is significantly different in comparison to the endoscopic and percutaneous management. So you can straightforward answer and read this article also. It is very, very informative and discussion is wonderful. These are the, otherwise most of the points have been covered. We do fibroscan before going for endoscopy. And if our fibroscan is significantly raised, more than 6 months, if patient has been there, recurrent problem, then we go for fibroscan. And if fibroscan has been significantly raised, then we follow upper GI endoscopy. Thank you.
Thank you, sir. Pradeep?
So good morning. Can I?
Yeah, listen, please. Yeah.
Regarding splenomegaly, he mentioned only biliary cirrhosis. But there are multiple causes. Recurrent cholangitis can cause splenomegaly. The rare event of portal injury, there can also splenomegaly. Sometimes there can also hemolytic anemias like, say, spirocytosis and all. Splenomegaly can be there. And unrelated cause also will be there. So there are multiple causes of splenomegaly. Regarding keeping the drain, not only bile duct injury, but there is excess bleed also people keep drain. When the cystidex is not secured properly, whether it ligature or clip also, they keep drain and all. And you mentioned that there will not be any early dilatation of intrahepatic biliary radicus. That is not the dictum. Of course, when there is biliary obstruction, by extrahepatic bile duct is instantaneous. But it may take up to 2 weeks for it to dilate. That doesn't mean that will not dilate the next day and all. Any number of cases we have seen in CBD obstruction by stones and sudden obstruction, we've seen mild ISO dilatation and all. So that is not the dictum. There can be any dilatation also in ISBRD. And while mobilizing the liver, when you suspect vascular injury, don't mobilize extensively the liver. It is supplied by the extensive collaterals from some 26 collaterals from everywhere. Another difficulty in managing bile duct injury is overhanging liver, this one, segment 4 or quadrant lobe is adherent closely. That may mislead, okay, we have reached the hilum and all those things and all. These are a few points I wanted to tell. Thank you.
Thanks. Yes, sir. Thanks. Pradeep, to wind up? Yeah.
Yeah. Sorry, stuck in an emergency. I just came. If there are no more comments, can I wind up, sir?
Yeah, fine.
Thank you, sir.
Thank you. Thanks.
Thank you, Shabeer. Thank you.
Vignesh, you've done well.
Thank you, sir.
Thank you. Thank you, sir.